Counseling 6303, Houston Baptist University, Chapter 14, presented by Dr. John Spody. Sexuality, Difficulties, and Solutions. Introduction. Sexual satisfaction is subjective. One crucial component to sexual satisfaction is the mutual pleasure of both sexual partners. Sexual problems are quite common. One set of sexual problems is related to lack of interest in sexual activity, difficulty with arousal, or the orgasm components of sex. These types of disorders may or may not cause emotional or psychological distress, and they can be associated with overall well-being and life satisfaction. Pleasure of sexual interaction ratings. In Figure 14.1, men and women worldwide were asked, how physically pleasurable is your relationship? The Pfizer Global Study of Sexual Attitudes and Behaviors, the first worldwide study of its kind, surveyed more than 26,000 men and women in 29 countries around the globe. Table 14.1 reports the prevalence of sexual problems by selected demographic characteristics. Sexual problems are most common among women and older men. Specific sexual difficulties. Specific problems that people encounter. They encounter issues with desire, excitement, or orgasm. They experience issues related to pain during intercourse. They can have lifelong or acquired difficulties. And they can have difficulties that are generalized or situational. Desire-Phase Difficulties. Hypoactive sexual desire disorders. This relates to the lack of interest prior to and during sexual activity. It is commonplace for both men and women. Desire discrepancies. Discrepancies in preferences for frequency, type, and timing of sexual activity can occur between two sexual partners. Sexual aversion. Sexual aversion ranges from feelings of discomfort to extreme, irrational fear of sexual activity. Excitement phase difficulties. Female sexual arousal disorder. In female sexual arousal disorder, genital, subjective, and combined genital and subjective sexual arousal disorders can occur. Persistent sexual arousal disorders are spontaneous, intrusive, and unwanted genital arousal in the absence of sexual interest. Male erectile disorder consists of recurrent inability to have or maintain an erection. Orgasm-Phase Difficulties. Female orgasmic disorder is the absence, marked delayed, or diminished intensity of orgasm despite high subjective arousal. Female orgasm during intercourse. Many more women experience orgasm from masturbation, manual stimulation, and oral sex. Male orgasmic disorder, a delayed or inhibited ejaculation. Orgasm phase difficulties continued. Faking orgasm. This is common in women. A growing number of men also fake orgasm. Reasons. Avoid disappointing or hurting partner. A desire to get sex over with. An attempt to appear normal during sexual activity. Have you ever faked an orgasm? In Table 14.2, college students answered questions, have you ever faked an orgasm? Dyspareunia. Dyspareunia includes such things as painful intercourse, experienced by men and women, but it's more common in women. Dyspareunia in men can be caused by infected or irritated foreskin, pelvic, or genital infections. Dyspareunia in women can be genitopelvic pain, penetration disorder, inadequate lubrication, infection, or endometriosis. Vaginismus is a strong involuntary contraction of muscles in the outer third of the vagina, usually preceded by a history of painful intercourse. The contraction prevention can be learned, but women do not consciously will them to occur. Some women are sexually responsive and orgasmic with manual and oral stimulation. Origins of sexual difficulties. Physiological factors. Some of the factors related to physiological issues with sexual difficulty include hormonal, vascular, and neurological. Good health habits equal good sex functioning. Chronic illnesses may impair sexual illness and response. Some of these can include diabetes, cancer, and multiple sclerosis. Medications may have a negative effect, both psychiatric and antihypertensive medications. Disabilities have widely varying effects on sexual responsiveness. Spinal cord injury, cerebral palsy, blindness, and deafness can have an effect on sexual responsiveness. Enhancement strategies for people with chronic illness and disabilities. The best way to cope is accepting limitations and developing options from what remains. Cultural influences. These include negative childhood learning or modeling, sexual double standards related to gender roles, narrow definition of sexuality, notion that sex equals penile vaginal intercourse, and performance anxiety. Individual factors include sexual knowledge and attitudes, self-concept, emotional difficulties, and sexual abuse and assault. Relationship factors include unresolved resentments, lack of trust, dislike of partner, ineffective communication, fears about pregnancy or sexually transmitted infections, sexual orientation. Basic and sexual enhancement and sex therapy. Self-awareness. Become well acquainted with your own sexual anatomy. Communication. Have partners participate together in the communication process about sex and how to increase enjoyment of sex. Sensate focus. Touching and communication can enhance sexual pleasure and reduce performance pressure. Specific suggestions for women. Becoming orgasmic. Some suggestions to increase the likelihood of orgasm include self-stimulation. A woman who does not have a partner can learn to become orgasmic. Experiencing orgasm with a partner. Masturbation in presence of the partner, and several techniques to increase arousal during intercourse. In dealing with vaginismus, relaxation and self-awareness exercises. Specific suggestions for men, specifically around the issue of lasting longer during intercourse. Ejaculate more frequently. Change positions, talk to each other, consider alternative activities, the stop-start technique, and medical treatment. Dealing with erectile dysfunction. Psychologically, reduce performance anxiety through medication such as Viagra, mechanical devices such as a suction pump, and surgical treatment such as implanted penile prosthesis. Reducing male orgasmic disorder, steps include sensate focus, partner stimulation, and penetration. Treating hypoactive sexual desire disorder. Many of the same suggestions for resolving other sexual problems apply to this disorder. Most therapists combine suggestions for specific activities with insight therapy. Medical treatments can also be considered, including testosterone supplements. Seeking professional assistance. What happens in therapy? Problems and goals are identified and clarified. Medical, sexual, and relationship history are discussed. Assignments are often given to complete between sessions. Selecting a therapist. Referrals from trusted sources are a good place to start. Ask potential therapists about their credentials, training, and experience. Interview to determine if the therapist can meet your needs. Unethical relationships. Sex between therapist and client. Boundaries must be set that ensure integrity of the therapeutic relationship. It is illegal to have a sexual relationship with a client if you are a therapist. Summary. Sexual health is a state of physical, emotional, mental, and sexual well-being. Sexual problems can contribute to lower satisfaction with overall life. Good sexual functioning correlates with good, healthy habits. Exploring one's own body, sharing knowledge of the partner, and establishing good communication are important elements of therapy.